in several clinics here at the dental school. We have one in pediatric clinic. We have one in the oral surgery clinic where we go and watch the dental students, dentists there practice actual oral surgery and pediatric dentistry in the pediatric clinic. And we are trying to start up a new one in the special patients clinic. So special patients are those who are compromised physically, mentally, and it's just a fascinating area to get to experience because you don't get to choose who your patients are when you become a dentist. So we are trying to get that for you guys. And today our speakers are going to be representatives from the pediatric oral surgery and special patients clinic. So you guys will actually get a first look at what all these clinics do and kind of get your first look into it before you guys start off rotations. And then before we start all those speeches, and do you guys want to come up? Do you have announcements to make? Well,
Okay, so instead of doing intramurals, we've decided that we're going to do Kicks for Kids, which is a volunteer program on Sunday, like mid-mornings for like 2 to 3 hours. And that you're just like volunteering with kids in the community and teaching them soccer. So we've decided that that's going to be kind of like a sign-up basis like SSC, and that's going to be a wild card point. So we're going to do, if you've signed up before, we're going to take other people, but you're always welcome to go anyway and not get the wild card because it's a great volunteer opportunity. And then our second social is going to be next Thursday, and that's going to be the Scrubs party. So yeah, you guys are all going to have to wear scrubs to that. And it's going to be at Gateway. So it's going to start at 9. I hope you guys all know where Gateway is. We tried to keep it as close to campus as possible and kind of as a central location. So yeah, that's my only announcement.
Rooftop.
yeah, it's on the Gateway
Rooftop.
rooftop.
Yes.
Tiny room.
It's on the rooftop. We're going fancy this year. So on top of that, before Colin talks about SSC, we have our new member interviews next Wednesday. So for those of you who are here and are able to make it to meetings, we will be interviewing new members. For those of you who have class conflicts, we understand that sometimes. I should be talking to the camera because clearly it's not here, but we understand that some people have class conflicts, so we scheduled secondary new member interviews for those who do have class conflicts. The first UDA event is on Saturday, September 28th, so you'll be receiving an email about that. And then we have our first workshop, which is drilling, which I told you guys about at the first meeting, and that's going to be on Monday, September 30th at 5 p.m. So look out for all this stuff. September's a packed month. We're going to have lots of fun. Colin?
Hey guys, so it's our third week of SSC. Hopefully you've all been getting the emails. If you haven't, come talk to me after the meeting and I'll make sure to get you on the email list. So this Friday, SSC, 8:10 in the morning, and then we're going to have our first breakfast with the board, and which will be pretty fun. I think we're going to go to Jack and Joe's, so that if you're signed up for SSC and you also want to come get breakfast with your board members, talk a little bit, have a good breakfast, it'll be some fun.
How long will you be there for?
We'll probably be from like 9 to 10:30, somewhere around there. I know I have to go at like 11 for a lab, so yeah, and we'll be providing rides too, for anybody who needs it. Also, I just sent out the confirmation email, so don't check when the speakers are talking, but check when you have some time. Then also, for those of you who feel like you might be getting ill or anything comes up where you think you're not going to be able to make it, please notify me Thursday night at 9 p.m. at the latest, so that way I can try to get in somebody to fill your position for that next day.
So if you're feeling even the tiniest bit sick, you're sneezing or coughing even a little bit, don't take the risk. Don't get the kids sick. It's not worth it. And give someone else that spot to go to SSC and call them up.
Yes, I just got over the flu. It's going around. I know lots of people have been getting sick, so just keep that in mind when you're signing up, and also the Thursday before the actual SSC, so that way we can know and other people have an opportunity. But otherwise, that's it.
Thank you guys. Okay. So from the pediatric clinic, we have an esteemed doctor. Everyone says amazing things about her, and we are very, very lucky to have her speak here. So, big round of applause to Dr. Hamdani.
Thank you. That was a lovely introduction. So I'm Sahar, the newly Dr. Sahar. I'm still getting used to the doctor. I actually just graduated dental school in May from here. And I'm currently a first-year pediatric resident here. So I'm here to kind of talk to you guys about pediatric dentistry, but Michael was telling me about some of the outreach stuff we do with going out in the community and teaching kids how to do their proper hygiene. So thank you for doing that. There's actually way too many kids, especially in LA County, for all the pediatric dentists to handle. So we need general dentists to help us too. And you guys will be going through dental school hopefully soon, one day. And whether or not you choose to go into pediatrics, if you decide to stay as a general dentist, you will be seeing kids. So it's imperative that you guys understand how to deal with kids, how to treat them, because their treatment plans are a little different than adults. A lot of it is, working with a different set of teeth, working with a different set of behavior and mentality and psychology. So it's good to get used to, handling with kids, talking to kids, all that stuff. So in advance, I tell you thank you, because you're going to help me out when I practice if you decide to be a general dentist with seeing kids too. So just to kind of give you a little bit of background about the program here and just about pediatric dentistry in general, we are the only specialty that is age defined. So we see kids up until about age 18 to 21. We also are responsible for adults that have special needs. They can either go to someone like Dr. Lent, who's going to be the one talking about special patients, but they're also, adults with syndromes and diseases, Down syndrome, all that. That actually falls under the realm of pediatric dentistry as well, so we can see those adults. So after you graduate dental school, you do a 2 to 3 year residency program. It's either going to be a university-based program, which is housed in a school just like USC or UCLA. We also have hospital-based programs where the program is strictly in the hospital. And then there's some that are combined. USC is actually a combined program because we are affiliated with 3 hospitals, affiliated with CHLA, which is Children's Hospital Los Angeles, Children's Hospital Orange County, and Long Beach Memorial. We're actually opening up a new site in the county hospital, LA County Hospital. It's a new clinic. So we're even going further into the community. So there's going to be 4 sites plus all the kids we see here. So we're a pretty strong program. We have also in LA, UCLA, and Loma Linda, but we actually have a bigger reach, which is great because we get a lot more experience, more diverse patients. We work with the well child to the medically compromised child, so we see everything. And here at USC, it's a 2-year program. So the first year, you're mainly in-house in the dental clinic downstairs in the basement, which you guys are all more than welcome to come and shadow us and help us out. And so that's the pedo clinic here. And then your second year, you become a resident of one of these hospitals, either CHLA, CHOC, or Long Beach. And you're there as a hospital employee for the full year. And you take call, you take emergencies, you're there 8 to 5. So you're actually a resident. You get paid, which is nice. So it's a little bit of a balance of a well-rounded program here. So during the 2 years, there's a lot of focus and emphasis on behavior management and child psychology. Because again, the dentistry that we do is pretty similar to what we do in adults, fillings, crowns, that sort of thing. The main difference is the behavior management. It's very different with kids. There's pharmaceutical, non-pharmaceutical. We do have a lot of pharmaceuticals that we use to aid us in children that are not cooperating and we need them to cooperate. We do what's called oral conscious sedation, which is very specific to kids. You don't do this in adults. What it is you're giving them some oral medication. They're conscious, so they're awake during their appointment. It's almost as if giving them alcohol. They get a little, loopy, and you pretty much get, you don't know what you're going to get. It's almost like a 50-50. You're going to get either the good happy drunk or the bad drunk. And so it's not always, it's true with kids too, it's not always a guarantee that they'll cooperate with you, but it's one of our child is put to sleep, so they're unconscious, and we get to do all the work there. And in addition to that, we're also really, we work a lot with their development. So we're always monitoring how they're developing. We work closely with pediatricians, children with cleft lip and palate. They have craniofacial teams that we work with to kind of help the kid along. Any type of oral and facial trauma becomes really important as a pediatric dentist, because kids, especially when they're really little and they don't have their motor skills completely, coordinated, they fall a lot and they break their front teeth. And so a lot of the trauma that we deal with, alongside with oral surgery, we also do that too. So those are just some of the stuff you get experience with during the residency program. So dealing with primary teeth, it's really important, and a lot of it comes down to two main things, which is prevention and education. I'll talk about that in a bit, but as you guys know, you have your baby teeth or your primary teeth, and there's a natural sequence to how they erupt, and there's a natural sequence to how they exfoliate, or when the teeth fall out. So this sequence is really important. It's nature's way of allowing these permanent teeth to have some kind of guide to kind of follow when they erupt, but it's also important that these teeth are not lost prematurely, because they do hold space for us. They're our natural space maintainers. So that's why it's really important that we take really good care of these primary teeth, because it also shows if that child is going to be at higher risk for developing decay in their permanent teeth. If they're already decayed in their primary teeth, high chance that if they're decayed in their primary teeth, and they're not taking care of it early, there's a high correlation that their permanent adult teeth are also going to be decayed. So again, the most important thing is they hold space. They're big space maintainers. When those teeth go, it allows for the mouth to kind of shift forward, and we get space loss issues. Just aesthetics are not the same anymore, so it's really important that we want to keep those teeth until they're ready to go out on their own. So similar to as just a regular dentist, a general dentist, but again, emphasizing more on the prevention and education. And you're not only educating the child, but you're educating their parents. A lot of times, the awareness is just not out there. And you guys probably know this when you go and you teach kids, they just don't know. And so it's our responsibility to make sure they do know, and that they do follow through, and they are seeing their dentist regularly. And so again, we go through their medical history. We take the necessary radiographs to be able to fully diagnose and treat these kids. So decay is one thing. A lot of times kids have extra teeth, especially in the middle of teeth number 8 and 9, which are the two central incisors. They usually get what's called a mesiodens, which is really common in kids. So we are able to diagnose things like that, any extra teeth, or if teeth are missing, congenitally missing. Any type of parafunctional habits, whether they're sucking their thumb or using a pacifier, those all affect the occlusion of the teeth. And so we are able to, hopefully when the kid comes early, detect these problems and prevent them from becoming problems. We kind of look at the whole picture, and we're able to assess what kind of treatment we want to do. So again, we kind of went over this. Cleft lip and palate, we also deal with that because a lot of times it affects their dentition and what teeth they have. They sometimes get congenitally missing teeth. When they're born, it's a really big issue because they can't feed properly, so we make different appliances for them so they're able to suck on the mother's nipple, because when they have the cleft lip and palate, their palate's actually open, and there's that open communication between the nose and the mouth and all that stuff. So the most important thing is getting that somehow closed so that they can properly feed and they can have their proper diet as a baby. And then when they get older, they do a series of different surgeries to repair the cleft lip and palate. So we work along with that, and usually they're going to need some type of ortho, so we also work really closely with orthodontists. And so all kids that have cleft lip and palates have a craniofacial team. Usually they're a patient in the hospital. They have a team that follows them routinely throughout their childhood, because these are special cases that need to have them monitored. So the different types of prevention that we do, again, having them come in early, coming in for their regular checkups. We do sealants, especially on their molars and their pit fissures, which is the deep grooves on the molar teeth. So those are very susceptible to caries, especially when they're back there and they're not brushing properly. So if we can get sealants on all those teeth, we can prevent them from getting cavities in the first place. We also do a lot of fluoride treatments, fluoride supplements. Fluoride has been shown to be able to remineralize decay that initially starts in the teeth. So if we can get them in, again, getting them in early before it becomes a cavitated lesion, we can prevent it from becoming something big by giving them something like fluoride. And the education, again, hygiene is the most important. Educating them about their diet. Again, they just don't know that, a lot of times I'll get moms and I'm asking them, like, what are they giving their child? And they're like, oh, well, I'm only giving 100% natural, no sugar added juice. I'm thinking, okay, well, there's still sugar in the juice. There's still, even though there's no sugar added, juice is the worst thing you can give to a kid. So we want to make sure that they understand that if they're going to have juice, it's with a meal only. If they're going to have it, they're at least following it with water or something like that. So this is really important because kids are not brushing their teeth. I can guarantee you that, especially when they're little. So that's why we need the parents on board to help us with getting the kids to brush their teeth and floss and all that stuff. So any oral habits, if we start seeing that the child has a thumb sucking habit or a pacifier habit, we want to make sure we let the parents know, well, by age 3 we want that to stop, because once all their teeth are in and they're fully there, we don't want them to affect the occlusion. And we also do a big part of pedo is anticipatory guidance. And what that is when the child comes in with their parent, you want to be able to tell them what's going to be happening in the near future to prepare them for what's going to happen, such as if they're teething, you want to let the parent know what to expect. Their diet, if they're breastfeeding now and they need to transition to bottle feeding or cup feeding, we want to kind of guide them through that. If the child is starting to learn how to walk, we want to talk about, okay, what happens if, the kid falls down? We want to inform the parent. So this is all anticipatory guidance to get them familiar with if something goes wrong, what can they do and what to expect. So malocclusions, pediatric dentists are actually hopefully the first ones to detect this. If they're coming soon enough to you before it gets to the orthodontist, we usually are able to see what's going on and we can detect any problems with occlusion. And hopefully if we detect it, we can do something about it early on, and this way it'll help them in the future, prevent them from having to get, longer surgeries or longer ortho treatments, that sort of thing. If we can get in there and kind of fix little things here and there with some appliances, maybe this can help them with shorter treatment in the future. So I talked about us being able to see some supernumerary teeth. If we see something there that shouldn't be there, we can again assess that early and fix that problem. Thumb sucking, we want this to stop by age 3. By age 3 you have about all your primary teeth, and so what happens is when you are sucking your thumb or you're sucking on a pacifier, it can actually start flaring out teeth and shifting them in different directions. So we want to make sure that when the kid gets to a certain age, they're not doing this anymore. So again, having them come in, explain to the mom what's going on, and therefore preventing them having to go through ortho in the future. There's also appliances we could use that kind of prevents them from sucking on their thumb. This is a thumb holly appliance where it actually prevents them from putting their thumb into their palate. So it kind of guides the patient into not doing it anymore. So it kind of helps us. Another big problem is baby bottle tooth decay or early childhood caries. When parents are using a bottle and they just don't know, especially when they're putting their kids to sleep with a bottle of milk, they don't understand that there's still sugar in that milk, and when that milk is bathing the front teeth all night, there's all these caries are going to form, and especially on the front teeth, they're harder to treat. So a lot of times we have to go to the extreme of extraction. It's not because we can't just put a filling, but usually what happens is these teeth are susceptible to large decay, and it's so close to the pulp, because on primary teeth, the pulps are a lot larger than the permanent teeth, and we have thinner enamel, thinner dentin, so there's a different morphology with primary teeth. So the caries process is a little faster. So we need to be a little more, wary of something like this, because it can get to the point where it can affect that permanent tooth. Okay, so we kind of talked about this a little bit. So it's really important that we want the public to know that kids need to come to see their dentist for the first time as soon as that first tooth erupts and no later than their first birthday. So it's really important that by age 1, every kid out there comes and sees their dentist. And again, it's more about prevention. The sooner we get these kids in, we get them accustomed to coming to, sitting in a dental chair, having people in their mouth, the less fearful they are going to be in the future, and the more likely they'll be good cooperative patients. And again, we kind of talked about fluoride. Fluoride helps us remineralize teeth. The caries process is a very dynamic process. It's not like a stagnant thing that once it happens, it can't be reversed. If it's in enamel and we have the fluoride there, we can remineralize and we can prevent this from becoming a cavitated lesion. So we want, fluoride's good. We want kids to be able to have their proper dosage of fluoride, whether they have it in their water or they have supplements or toothpaste and all that stuff. We want them to have it. So it's really important that they understand, the parents understand that fluoride's good for them. And of course, talking to the parents about healthy snack choices, having veggies, dried meats, cheeses, this stuff, and not so much of the sticky, gooey candies and treats. Because again, a lot of them don't know, and especially the juices. Make sure to tell your parents, no, we don't want that much fruit juice in their diet. And dental emergencies. So if we want to tell the parents that if the kid does fall and a tooth comes out, to make sure that if it's a primary tooth, it's okay. It's okay if it falls out. We don't want to reimplant it. But if it's a permanent tooth, we want to make sure that we get that tooth in some type of liquid. And usually, almost everyone has milk at their home. Milk is actually a really good liquid to kind of carry the tooth in until you can come to your dental office and have the dentist put the tooth back in. So we want to kind of inform our parents that if something like this happens, if a tooth does get knocked out, look for it. And if you can find it, put it in some milk and just go to your dental office, and hopefully your dentist can help you. So I kind of flew through that. Does anyone have any questions about what I presented on or the program here? And here's my email. If you guys have any questions, feel free to email me. And please come down to our pedo clinic on the basement and help us out. It's a fun place.
Perfect. Thank you so much, Dr. Hunter. Okay, so up next from the oral surgery department, we have Dr. Toon. So.
I'm going to talk about our department, oral and maxillofacial surgery department. According to the definition, that is the specialty of dentistry, which includes diagnosis, surgical, and adjunctive treatment of diseases, injuries, and defects. I think the pediatric doctor mentioned about the defect. Regarding the defect, we have developmental and acquired. Developmental defect is what she has mentioned, cleft lip, cleft palate. It is more common in Asian than the Western people, involving the functional. The functional is when we have facial trauma. When the bone is fractured, we reduce and we stabilize, fix. But the facial region is when you have trauma, maxillofacial surgeon deal the case, plastic surgeon, and ENT. Nowadays, the dermatologist and the ophthalmologist, they deal the fracture. The problem is when there is broken bone, they try to put the bone back into position, but they don't know about occlusion. So the bone has been set, but the patient is unable to occlude or unable to chew. We have to refracture it and put back into occlusion as well. That is why function is also important, and aesthetics. Aesthetics, since we are dealing with the face, aesthetic is also important. For example, if a 16-year-old beautiful girl come to see you with an abscess here, when you have an abscess, it should be drained extraorally, cannot drain intraorally. So if we are going to incise that abscess, definitely there is going to be a scar. And another thing is, when we do surgery in and around the face, we have to think about the anatomical important structures. What important structures around this is the facial nerve. Facial nerve, it supplies the muscles of the face. When you cut it here, you might cut one of the facial nerves, and the patient might have facial paresis, that is called Bell's palsy. So aesthetic, we have to deal with the aesthetic aspects, and we are dealing with the hard tissue. Hard tissue means bone and teeth, and soft tissue of the oral and maxillofacial region. Maxillofacial is, we are from the brow to the lower border of the mandible, and inside we go up to the oropharynx. That is the territory of the oral and maxillofacial surgery. Since oral and maxillofacial surgery is a combination of medicine and surgery, we have to deal more with medicine, because dentistry is an art as well as science. So, but we have to combine with medicine. We do more invasive procedure. That is, we have more morbidity and mortality. So, what is the best way? The best thing is prevention. How are we going to prevent those complications? For example, when the patient comes to see you, the patient might have underlying condition. One of the fatal underlying condition is they might have heart problems. They come to see you, maybe, but if you don't take proper history and examination, if you miss that cardiac disease, the patient may die in the chair or any time. So you have to know a lot about medicine. What are the diseases and condition might cause a patient to die in the chair. Okay? And another thing is, when we are going to do extraction, so according to some of the books written, a surgeon should have qualification that eyes of an hawk. His eyes is very sharp. Whenever a patient comes in, you have to look at the patient, and by looking at the patient, you have some clue what the patient might have and what the underlying condition might have. So eyes of a hawk and heart of a lion, because when the lion they are going to attack the prey, they have the same effect, whether the small or the big. For the surgeon, we don't know. A tooth, it looks like simple. Maybe the tooth may be like a girl. We don't know what might be. So if you expect that it is simple and we don't use that much fork and extract, there might be complications. And another one is, especially the surgeon, when you are dealing with cancer patient. Because in cancer patient, we are tying the loose pedal because the patient will die. In that case, you have to be courageous, and at the same time, you might not let your emotion and feeling towards the patient. That is, you should have the heart of the lion. And another thing is hands of a lady, because in the books it written, if you treat the tissue with loving care, they will heal in the same manner. According to Newton's first law, when there is an action, there is almost an opposite and equal reaction. So whenever you examine the patient, you should be as much gentle as possible. Those are some of the qualities of a surgeon. in oral and maxillofacial surgery at our school, we have two departments. One is at school, another is the hospital. At the school, what we do is exodontia. Exodontia is extraction of the tooth, and we do some minor oral surgery. That is, we usually do with local anesthesia or with or without sedation. The reason we use sedation is most of the dental patient, they are anxious, they have under stress. If we sedate, we lessen the stress. And at the same time, especially to the children, what is important is when you sedate, they forget the unpleasant feeling or unpleasant sensation at the time of surgery. That is the beauty of giving sedation. That is why sedation is now very popular, especially with the children. For example, if you are going to treat children, you are not treating the pathology of the children. You have to treat the children so that they might not have dental phobia, maybe to you and the other dentists as well. And the maxillofacial surgery is we usually done under general anesthesia. So after DDS, if you want to be an oral and maxillofacial surgeon in the US, because whenever you go, there are two. One is 4 years oral and maxillofacial surgery training. That is, they give you a diploma. Another one is 6 years. That is, they have DDS as well as MD. The good thing about DDS MD is after DDS MD, you are able to do facial plastic surgery and craniofacial surgery, head and neck surgery, oncology. Regarding facial plastic surgery, we have reconstructive and aesthetic surgery. Reconstructive is when they have a defect. We try to correct the defect. Aesthetic surgery is when they want to be more handsome, more beautiful. We will deal with the aesthetic surgery. But in aesthetic surgery, what is important is you have to choose proper type of patient. If you are going to choose a patient like Michael Jackson, you are going to be failed, okay? That is plastic surgery. Another thing is craniofacial surgery. Craniofacial surgery is we not only do the face, we do the skull as well, but we don't touch the brain. And another is head and neck surgery on oncology. That is, now it's very popular now, because the reason is when the patient has cancer, because cancer itself might kill the patient, what is most important thing is the psycho effect. That by knowing cancer, because of the psychology, the patient might die, not from the disease, but from the psychological effect, okay? And another one is after those, you might have the fellowship training and you get diploma, American Board of Oral and Maxillofacial Surgery. Can I?
Sure.
So oral and maxillofacial surgery, we do oral surgery, pre-prosthetic and implant surgery. Because implant nowadays, implant is very popular. We don't use inside the mouth, we do facial implant as well. In the past, when they don't have the nose, we cannot reconstruct it, so we use a plastic nose. But in order to be stabilized there, we might need to have something like the eyepiece there. Nowadays, because of the implant, we don't need to just put the implant and stuck the prosthesis on it. And we have to know about head and neck infection, because infection might kill the patient, and odontogenic diseases of facial sinuses, because since we are close to the sinuses and the salivary glands around here, and pathology, that is about the cancer, and we have to deal with the trauma We have to deal with the dental facial deformities, developmental, acquired. We have to do aesthetic, facial aesthetic and reconstructive surgery, and we have to deal with the temporomandibular joint and facial neuropathy. So, any questions you would like to ask?
Anyone going to save questions for the end? If that's okay with you?
Oh, sorry.
Yeah,
No,
absolutely.
sorry.
Go ahead. Again, so thank you very much. Oral surgery is an incredible field, and I actually remember my first time in rotations, and I was watching Dr. Toon. He's like a god in there. So everyone highly respects him, and he's just an amazing oral surgeon. So next we will have Dr. Lent.
Now you have geriatric, and I'm right from the nursing home right now. Luckily, there was not that much traffic on the 10. Okay, I have how many people under the age of 30 who can help me if this doesn't work? Yeah. Any doubt? Okay, just let me get this up. Hold on, let me help. Detect displays. Come on, detect one display. I think you need to get more of this. Okay, now, the rubber meets the road. Who here was IT in a former life? There's always one. Those of you, you want to get that? Those of you who were IT in a former life, you will find everyone here is pre-dentist. That is so cool. You don't know how refreshing this is. You know why? Because my kid just started USC and he is definitely not pre-dent. Every time he changes major, he's not pre-dent. So this gives me hope. And I don't care, I'm low tech. I'll turn this thing around and put it on a desk and show you how to. Anyway, let me just start because I know we've got a time crunch. Yes, yes. Get out of the IT. You can make it for sure. Oh, you know what? Hi, I am Janet Lind, and I am a senior faculty in special patients clinic here at Ostro. I did 25 years in general practice and then came back to my alma mater here to teach. I ran through dental school way before you guys were born. I graduated in '78, and I can't work a day here without thank you, because our clinic, special patients clinic, fits kind of like a sushi. They're the rice, and these fit all the way around. Oral surgery, special patients clinic goes all the way around, and we work very closely together, and it's wonderful. Okay, so I'm here to just do a little talk about special patients clinic, special patients in general, special patients clinic in particular, and we have, you know, if you ever wondered where do the double lung transplant patients go, where do the heart transplant patients, the renal dialysis, the majorly complex patients go when they're not getting teeth out or their face resected, they need general dentistry. And they go to you guys, they go to the general practitioners, but how do you know how to deal with them? Hopefully in a dental school, whatever dental school, the 5 dental schools, 10 dental schools, you guys each get accepted to, and you take your pick. Hopefully you pick one that has a really good special needs dentistry department. Okay, so this is an overview of kind of what the issues are. Who are special patients? They are us. One of the privileges of working with special needs patients of all kinds is that you things happen in the world and you kind of get to see the fallout. And we get to expose people like you to see these people as people, to see these patients as people. How many times do you go by someone in a wheelchair and just look straight past them, like they don't exist? Well, everyone knew Christopher Reeves when he was Superman. Then his horse refused the 2-foot jump, and this big guy landed on his head, and his body went over like that, and he had a C1 fracture, and there he is while he was still alive in his wheelchair. And he made it one of his missions to go and talk to people and educate themselves, and educate them and say, see me, I'm still the same guy. Okay, so it's a really cool clinic. This is one of our 80-something full of moxie people. Well, that's pretty sharp, you can see that? And so our big question in special patients is, why are you here? What makes you so special? And some of the people that you'll find in a special needs clinic are people with ID, that's intellectual disability. People who are really medically complex. And I'm not talking about a little bit of diabetes, hypertension, and hyperlipidemia, because America has that, because America eats like America eats. And so everybody's got diabetes, and don't exercise and all that. You guys all exercise. I just came from the nursing home. It's the nicest thing you can do for your 90-year-old self. And we get people with insulin-dependent diabetes and hypertension and a severe renal disease, people with hypertension who had a stroke. So if they come in and they say, we say, why are you here? And they say, oh, I have hypertension. It's like, no. Don't care about the hypertension. If it's really out of control, you shouldn't even be here, go to the hospital. How about the stroke that it caused you? And that's kind of who we see. And we also see geriatric patients, people who are 80 or more. By the time you see like Doña Amelia, I saw her today, she's 104. She's just physiologically not like you guys anymore. And you have to know what the treatment modifications are. And that's the whole point of special patients. Treatment. Who are they? What are their needs? How do you have to modify regular dental practice to safely treat them? And it never meets the road, the rubber meets the road no harder than in oral surgery, because they're usually cutting people open, or I'm sorry, that's a bad way to put it. They're quite invasive over there. And even so, we're pretty invasive too. And so you have to understand, what medications are issued. Can you lay her back? If you lay her back, is she going to drown because her lungs are filled with fluid because she's got congestive heart failure? But, we've got all kinds of people in our clinic. This is an adult patient who's got autism, so we kind of load her down with heavy blankets. She likes that. She feels more secure. People with cerebral palsy. All you colleagues will recognize this is Becky. She's got Down syndrome. And it runs the gamut, the spectrum. Just, you can have 50 different things literally wrong with you. Cardiological things and other things if you've got Down syndrome. Or it could be just like treating any patient right off the street. And then you've got some of our more flamboyant people. Ray there has different problems than just wearing and making big hats, but you're going to see a lot of people there. And this indeed is Doña Amelia. She's our award winner in the skilled nursing facility. She's 104, and she actually abscessed. And who were the heroes who treated her? Oral surgery at USC. They're not afraid of a 104-year-old. Bring her on in. And she's doing the climate, by the way. This is John. John had early dementia. He's big, he's strong, he's aggressive, and he has not too much cognitive function. Anybody know what's going on with the guy in the middle? What do you think? What's this thing in his arm? Yes, it is dialysis, and that is a shunt. So we treat a lot of end-stage renal disease people. Maybe Omicron. There's some medical conditions you might find out. These legs are attached to a really wonderful 87-year-old. But that's not the point. What's with the red stuff? You guys know what the red spots are? Ever seen any of those? It's not senile purpura, which you sometimes see on really old people. You see these patches and stuff. No. She's on Coumadin. She bumps herself and she gets a bit of a bleed. So one of the things we train all of our dental students is to watch them walk in. Take a look at their arms. Look at their ankles. Any swelling. Shake their hands. What's the grip like? What's the facial color? Look at the eyes. It's as Dr. Toon said, you have to really be a student, a student of your patient every single time. And I mean, they could have come in yesterday and it's very different today. What's going on with the hands? This is not ethnic coloring of any sort. Why is this one yellow orange and that one pink? Any idea what would cause someone to look like that?
Liver failure?
Pardon?
Liver failure?
Actually, it could have been liver failure, but no, in this case, it's kidney failure. And these kidneys are not working, end-stage renal disease, and this guy basically has blood pigments buildup and he's turning. This is the skin shot of the lecture, so what do you think it is, guys? Does this person look like, like they weigh milk 6 million pounds? No. Again, you always observe, this patient is AIDS, has an AIDS, and is wasted. So he tends to drop a lot of weight. We're trying very hard to get him back up into it. We see a lot of AIDS patients, sometimes co-infected with HIV in our clinic, and they can be very medically challenging to handle. Now, okay, so your patients have various and sundry illnesses. So what? You know, you get the treatment modifications. Where does it end? Well, it keeps going. You are their dentist. You have to make sure they have adequate oral hygiene. You have to make sure they can comply with some of the post-op instructions. What do you think's going on with the hands here? What do they have? What's your hand? Do you know? Yeah. No, it's not. Oh, arthritis. Yeah, no. But, I mean, this is bad. This is called dorsal drift. She's got rheumatoid arthritis. And once you come and study, it's, as Dr. Toon said, you really have to understand medicine. And it's not just if you're going to be an oral surgeon. It used to be, if you were going to be an oral surgeon, those are the only people who really need to know it, because I'm just going to be a general dentist. Well, take a good look. The baby boom is coming. There are going to be well over 70 million of us in 2030, and that will be well within your practice lifetime. And because we didn't have sealants, and we couldn't prevent a lot of the cavities, we didn't understand about the major disease, like the disease of caries, that causes the symptom, a cavity. We have lots of restorations, and you're going to be seeing lots and lots of baby boomers. What's more, we're going to be alive and with teeth. A lot of the slides I showed you, those people weren't alive in the 70s when I was in dental school, because if they had something bad enough, they would die. Well, now medicine is really keeping them going a longer way. And so we're going to have to really be physicians of the oral cavity, to be general practitioners, or anything else, certainly specialists. Is this too scary? This is actually exciting. This is going to be interesting. And the more you know, the better it is. So anyway, we had to adapt. See the resin? She can't get her hand really close. You have to be a little bit of an occupational therapist. Okay, what is that disease? I just told you what it is. What is it? The disease, number one disease is caries. It is a disease. The hole is not the disease. The cavity is not the disease. This is an infectious bacterial transmissible disease. Bidirectional disease of eyesight. And that person looks like someone in a nursing home. What's going on here? Anybody know? You ever like stuck? Oh, 2 more minutes? I better really. Dry mouth, calculus, meth mouth. A drug so bad that it has its own thing. Okay, I just put this in. This is Helen. I love Helen. She got resected. She had cancer. Obturator. As she said, I'm back, is what she said to the prosthodontist. And then when she put that obturator in, she looked at him clearly, smiled, and said, "You gave me my life back." All 4 months is left. This is a slide on interprofessional. What? This is Jimmy. This is Jimmy. He's our anesthesiologist, head of anesthesiology here. And these are all the people. Interprofessionalism means everybody talks to each other. And because people are getting so sick, and you have to treat them, you have to talk to everybody. Not just consulting oral surgeon and GP, you have to talk to all the medical people as well. Oral medicine people is one specialty, and they deal with very complex people and very complex medical histories as well as conditions. If you don't know what it is in the mouth, you call them an envelope often. There's Jimmy again, smiling, outpatient general anesthesia. Here we are at Hollenbach, where I just came from. It's a nursing home, skilled nursing facility. 1 more minute. Here's what you do in hospitals. You treat big infections. You might do major complex oral surgery. That bicycle chain is where they resect the tumor. This is what Dr. Toon was kind of talking about. And in postdoctoral training, after you're done with dental school, you'll have the ability to go and get a GPR, general practice residency in hospital, or an AEGD, which is an aesthetics program, or train for specialties and get certificates. So there are many careers you can do with dentistry. Some of them involve special needs patients. But take a look. I know these are just words to you. You will really get to know them, okay? We have our own organization, we're geriatrics. I want to put in a plug for my favorite organization in the world. And I want to thank you.
Perfect. Thank you.
Sorry, I usually can't say hello in 5 minutes. You're so nice.
So stay in your seats if you can. We have a few quick more announcements. We don't have time for question and answer sessions at the end, but we will post their PowerPoints online on our website. If they send them to us, and if they're kind enough, we'll get them to their emails so you guys can send them a few questions and not bombard them with emails, just a few questions. So new members, you'll be receiving official invites, like really nice invites for interviews. So look forward for that. And David has a quick announcement. So coming up, two? Okay, two announcements from David.
So the first one's about rotations. For all of you that were here 2 weeks ago and know about rotations, I actually was able to open up the oral surgery rotation next few weeks. So how it works is every couple weeks it changes the schedules, but pediatric rotation, the only option is going to be this upcoming Monday for 9 to 12 and 1 to 4, and then pediatric rotation is going to stop for a week and then start again starting October 2nd. It's going to be Wednesdays, Thursdays, Fridays from 9 to 12 and 1 to 4. You'd have to go for the entire 3 hours, but you pick whichever rotation you want. And then oral surgery is starting up next week, Mondays, Wednesdays, and Thursdays from 9 to 12 and 1 to 4. And keep in mind, you have to do at least 2 rotations for the entire year to be put on your, to be a cardinal, and 3 for a gold. So if you're interested, come up to me, write your name down, and I'll send an email to you. Yeah.
Wait, so for new members, we can't sign up until we get scrubs, right?
You can sign up until you get scrubs, and you guys cannot participate in rotations or IUTA until you all have your HIPAA certification.
Yeah, that's the most important thing for the certification. Can we get the announcement?
Go ahead.
Okay.
You can get your own scrubs too, you don't have to have, I know this will,
Huh?
I was just gonna say, you can wear, if you have scrubs already, you can wear your own scrubs.
Yeah, if you have your old scrubs from last year, she's talking to the returning members, you can wear those. For new members, we have new scrubs coming in, they're super nice, so look forward to those. And then,
So the other announcement I wanted to make was you all got an email a week ago, about my organization, mine and Miles, who's also a member of DDS. It's called Dental Volunteers Around the World. We're a dental service trip that goes to Dominican Republic every single summer, and we set up dental clinics and around the different communities, and we treat patients with extractions, cleanings, fillings, sealants. If you've ever been to IUTA, it's pretty much all undergraduates doing IUTA with a couple of dentists from the host country in clinics in Dominican Republic. And it's really sick, and we go for 14 days over the summer. And if you have any interest whatsoever, want to hear anything else, more information, come to me and I'll get you information, and we'll have an info session in a week or 2. And that's it. Thank you.
Alright guys, that's it for this meeting. Look forward to our next meeting. We will be having the Associate Dean of Academic Affairs and Student Life. We're going to learn how dental students at USC Dental School learn and are educated. So look forward to it. See you guys at the scrubs party.